My name is Frederick Ruberg from the Department of Medicine, section of Cardiovascular Medicine, and I'm a clinician scientist who studies transthyretin amyloid cardiomyopathy, which is a mouthful, so we'll call it ATTR-CM. I work with the Biomedicine Center, and I'm going to be presenting how ATTR-CM disproportionately impacts communities of color. Next slide, please, Brian. So ATTR-CM is a cause of congestive heart failure, and congestive heart failure disproportionately afflicts communities of color. It's the leading cause of hospitalization in the United States, and is projected to cost almost $70 billion and affect 8 million people in as little as 8 years. Despite our advances in treatment of congestive heart failure, disparities have still been observed by race and ethnicity. In fact, African Americans experienced a 2.5-fold increased risk of hospitalization or death from heart failure versus white patients. And as this graph illustrates, African American men, illustrated by the blue line, have the highest age-adjusted risk of heart failure death, whether they're young or old. Next slide, please. So ATTR cardiomyopathy is an underrecognized cause of heart failure that we study and treat at Boston University. It's a disease of aging where protein TTR misfolds and deposits in the heart, which impairs the function of the heart and causes congestive heart failure. Interestingly, it can be caused by a genetically inherited condition called V122I or Val122I-isoleucine that's present in 3.5% of African Americans, which translates into 1.5 million carriers of this risk allele. We don't know the prevalence of cardiac amyloidosis or the penetrance of this allele, but there may be as many as 100,000 undiagnosed carriers. Why are they undiagnosed? Because it was difficult to make this diagnosis until the advent of cardiac imaging, previously diagnosed only by biopsy. We know that the presence of this cardiac amyloidosis is dire. We've recently shown that the 5-year survival is only 43% compared to 66% in matched control subjects. The knowledge gap that we're trying to understand is what is the prevalence of ATTR cardiomyopathy in the African American population with heart failure? And secondly, why is this so important? It's important because we now have treatment for this disease. It was not treatable until about 2 years ago when FDA approved a therapy called tafamidis, which can treat ATTR amyloidosis. So by not identifying it, disparities in care are perpetuated. Next slide, please. So NHLBI funded us and Columbia University to perform this study called ScanMP, Screening for Cardiac Amyloidosis with Nuclear Imaging in Minority Populations. It's a 5-year study, and we're now in the end of our 2nd year, where we're recruiting 800 self-identified Black and Caribbean Hispanic patients with heart failure in Boston and New York City. Our objective is to explore the prevalence, the phenotype, and the outcomes of ATTR-CM in this important vulnerable population. We hypothesize that up to 10% of patients with unexplained heart failure have ATTR-CM. And while we have a number of sub-aims, one of the important ones is validation of a decision support tool that can be applied at the point of care that we reported a few years ago and need to validate in a larger population. Our preliminary observations are seen there. Of the first 200 subjects recruited, we've seen a prevalence of approximately 7%, slightly below our anticipated prevalence, but importantly, in those over 75, the prevalence was 16%. Next slide, please. In addition, we're trying to understand not only the biological implications, but also the systemic aspects of care and how they may impact our population of patients we're recruiting. So we were granted by NIH a COVID supplement to understand the capacities, attitudes, and barriers in our population for compliance with mitigation recommendations and the ability to protect themselves against COVID-19. Our goal is to understand the barriers that exist so that we can potentially target future interventions more effectively. And again, preliminary observations here, this study just started in October of last year when we received the grant money, but we've identified only, fortunately, 2 patients who've died from COVID-19, but 10% reported a prior diagnosis. And our objective is to compare diagnosis serologically with their responses to a questionnaire. But we've identified some important barriers that can be that could be intervened upon. First of all, inability to effectively isolate, as you would expect. A large proportion of our population live with essential workers. The financial stress and food insecurity was an important determinant. And finally, the psychological impact of the COVID-19 pandemic, isolation, and the result of that. So we hope by understanding these systemic impediments in elderly minority heart failure patients, we can target more effective public health interventions in the future. Thank you.